You're listening to Medscape's In Discussion series on esophageal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Samuel J. Klempner. Dr. Klempner is an associate professor and director of gastroesophageal medical oncology at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Relevant disclosures can be found with episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Sam Klempner. I'm a GI medical oncologist at Mass General in Boston, and welcome to this Medscape In Discussion esophageal cancer podcast series. Today, we're going to be discussing novel therapies for GE junction and esophageal and gastric adenocarcinomas. First, let me introduce my guest and friend, Dr. Zev Wainberg. Dr. Wainberg is a professor in the Department of Medicine and Surgery, as well as co-director of the GI Oncology program at the UCLA School of Medicine in Los Angeles, California. Welcome, Zev.
Thanks, Sam. Happy to be here.
So I thought we would take advantage of some of your research and expertise in this area and sort of walk us through standard of care case, and maybe we'll fill in some areas that are open questions and also future areas for development. Second line and later line GE junction, adeno, and esophageal is really quite a heterogeneous landscape of management. So I'm going to start out with just a typical case. Let's say 60-year-old woman, PD-L1, CPS 5, microsatellite stable, HER2 negative, didn't have a trial option in the front line, so you gave FOLFOX and nivolumab, and 11 months later, this patient is progressing. So I want to start by asking you, do you think about patterns of progression when we're thinking about what to do next? If someone has an isolated area, an escape lesion versus multifocal progression when you're thinking about transition from first line into later?
When we think about the patients who progress into second line, there are, as you point out correctly, I think very different patterns, and it really depends on probably the biology of the disease. Obviously, there are characteristics that make it more aggressive and less aggressive. Sometimes gastric cancers often follows a paradigm of colorectal cancer where you actually have been off oxaliplatin for a number of months and a patient progressed off of oxaliplatin, and I have seen some consider putting patients back on oxaliplatin at that juncture because the pattern of progression is not so aggressive. And there are other circumstances where the disease just progresses clinically and in a manner that requires us to make a very large adjustment to the treatment. I do think that this is probably a reflection of the heterogeneous manifestation of progression and which clones are determining the disease progression at that point. And we have to react according to the aggressiveness of the pace of the disease.
Yeah, I totally agree. I think we both see a lot of this cancer and have seen the whole spectrum. This is sort of a broad question, but you obviously been doing this since before checkpoint inhibitors were common in the front line. Do you think the patterns of progression have changed since we started using more chemo IO versus chemo alone? Do you think there's a different pattern in when people progress between those two approaches?
It's hard to say. I do think that what we see with checkpoint inhibitors is that primarily in the patients that have CPS5, we have improved frontline therapy significantly. That has led to both these so-called maintenance regimens that are often considered. And I don't mean to suggest that it represents a huge number of patients, but there are patients in whom after 4 to 6 months of chemotherapy with FOLFOX nivolumab, let's say, you can then keep the patient on less intense chemotherapy and a checkpoint inhibitor. And I do believe that group of patients is a fairly different group of patients than we used to see in the past. That's been hard to tease out in the studies and hard to determine how big it represents. But in my experience, at least, that is something perhaps nuanced that we didn't see before. We still see these patients ultimately progress. And the point is that if they're progressing at, let's say, 11 months, as in this case, that's a lot longer than we used to see. But it's certainly something that obviously happens in every patient.
You raise a good point. And the Armani trial that we'll see at ASCO in a couple months addressed this continuation versus early switch maintenance type approach. So interesting data to come. Let's say this patient has a clear progression, several new liver metastases, and a couple new lung mets. What is your sort of go-to for standard of care second-line therapy when you don't have a trial? Do you repeat biopsies on everybody? What's your typical approach when someone comes in needing to make a change from first to second line?
So with respect to repeating biopsies, I personally don't do it unless someone's HER2 positive, where I think we know for a number of years now that that's probably a useful endeavor. In the patients that have a fairly nondescript genomic profile, I don't routinely repeat biopsies. Sometimes I will do circulating tumor DNA just to see if there's any new clonal resistance mechanisms that may have emerged, particularly for interest in clinical trials. But I can't say I do that routinely. Now, with respect to standard of care, I think here we are still using paclitaxel ramucirumab, and that's been a little challenging in the field. We've made great strides on frontline therapy and expanding the options, whether they're with checkpoint inhibitors or other targeted therapies that are poised to enter the clinic. But I have to say, with respect to second-line therapy, I've been disappointed. I think we haven't done enough innovative clinical trial designs. There have been attempts, but we haven't had a huge effort to develop new drugs in second line, and it's a bit of a missed opportunity, in my opinion. Something hopefully we can correct the next few years.
I'm 100% with you there. Our friends Harry Yoon and Kohei Shitara have described this clinical observation that maybe after frontline checkpoint inhibitor containing therapy, the activity of Taxol and RAM or RAM containing regimens is enhanced. Anecdotally, is that something you've seen? Do you think this is real? I know there's maybe some debate about some prospective trials to test this.
Yeah, I think these are one of these things that are very hard to prospectively test because you have so many biases that are introduced and you end up drawing conclusions that are difficult to conclude. I will say that anecdotally, I do think there is something to that observation. Number one, that is the right therapy at that time. Whether they preceded treatment with a checkpoint inhibitor or not, the standard of care is still paclitaxel ramucirumab, and I don't think we would necessarily withhold a VEGF agent whether or not they had a checkpoint inhibitor beforehand. I will also point out that there are cases in which I do prefer FOLFIRI ramucirumab in this context, and those are the patients, perhaps, as we alluded to earlier, that had a good degree of maintenance success on 5-FU-based therapy, and I sometimes find myself somewhat interchangeably choosing between these two regimens where, as you know, there's been studies that have suggested they're very similar in their efficacy data.
Yeah. I want to tweak this case two ways. One, I'm going to make it HER2 positive, and other time I'm going to make it MMR deficient because I think these are, real world scenarios we face. So we both know that we have access to trastuzumab deruxtecan in second line and beyond after first line trastuzumab, and we also have Taxol and RAM for this same patient population technically. So let's say same case, but patient progressed on KEYNOTE-811 regimen, and now you biopsy and they're HER2 negative. Are you reaching for TDXD? Do you use the biopsy to guide, since we don't know whether there's a difference in the sequencing between PAC-RAM followed by TDXD or the other way around?
Yeah, I think that if they're HER2 negative now, I'm not reaching for TDXD anymore. If they're HER2 negative, I feel like we can't put all of our stock in a HER2 targeted therapy, especially one that doesn't have a combination platform with which to hedge our bets. So if it's really HER2 negative disease after frontline chemo trastuzumab combinations, I'm preferring PAC-RAM. This is obviously the subject of a very large international trial at the moment, comparing PAC-RAM to TDXD in second-line HER2 positive disease. And the key element is here, are enough patients truly HER2 positive? Because I think if that is not the case, then that may jeopardize best outcomes in that group. For people that are HER2 positive and are confirmed to be on a biopsy, then I think I would likely start with TDXD and reserve PAC-RAM for a third-line option.
I generally follow a similar approach, and I think DESTINY-Gastric04 is an important data set, but not the most straightforward trial to complete in a world where TDXD is available in many countries. I want to tweak this case again because this is an area that you led a lot of work in and thought a lot about in the MMR deficient or MSI high population. So it's pretty universal that everybody tests for this. And then if we find it at diagnosis, these patients are getting PD-1 containing regimens, whether it's FOLFOX plus PD-1 or PD-1 alone. Let's say same patient was MMR deficient, gave them FOLFOX, PD-1, you dropped the chemo, they were on PD-1 for 2 years, and now they progressed. Again, same question, are you biopsying this person? Have you seen loss of MMR deficiency or however you want to call it? And then what is your sort of go-to for second-line MSI high?
Yeah, this is a really good question, and actually probably going to emerge more and more as the time goes on, I imagine, because these patients with MSI high, first of all, are a little more common than we thought originally. And second of all, as recognition that this group of patients is distinct, they shouldn't be included in these trials anymore. So we're stuck thinking about what are the options. So I think in a patient who progressed and still has evidence of MMR deficiency, and the way I would characterize that evidence is either by immunohistochemistry or perhaps even better, some genomic sequencing at that juncture. The patterns of progression on MSI high cancers are very, very distinct from those with microsatellite stable cancers. There's, as we've talked about, Sam, not a huge amount of literature in this context. You've done some of that work, but the group of patients who are MMR deficient actually are heterogeneous in and of themselves. But someone who's been on 2 years of PD-1 therapy would suggest a true MMR deficient patient, and in whom I would try to think of a secondary immune manipulation. And there are studies that have looked at CTLA-4 combining with checkpoint inhibitors with TIGIT antibodies, checkpoint inhibitors with other checkpoint inhibitors like LAG-3 and others. And then this new group of drugs, Warren helicase inhibitors, which are, I think, very mechanistically good options for patients with MSI high disease, generally speaking, and would be fairly distinct from a checkpoint inhibitor strategy. We have lots of options what to do with these people before even resorting to chemotherapy, in fact.
I agree. Maybe for our broad audience, these are two really preclinical, really nice, both in nature, that came out quite recently, maybe even this week. For a lay audience, broad overview of what is this Werner's helicase thing all about?
Right. So Werner helicase represents a novel target of an enzyme called Werner helicase, WRN, and it represents a pathway that is what's called synthetically lethal for microsatellite instability. And what that means is that the presence of microsatellite unstable cells, which are MMR deficient, lend themselves to inhibition of this pathway. So if you're microsatellite stable, unfortunately, blockade of Werner helicase doesn't do much. But if you're MSI high, blockade of Werner helicase really shuts down dramatically tumor growth. And some of this very, very important work that was done preclinically a number of years ago has been clearly demonstrating as Werner helicase sets itself apart in these synthetic lethal screens, which have led to a number of drugs in development right now in phase 1 clinical trials. It's a great pathway for us to study the next few years in this group of patients.
Let's maybe push it a little bit. So you have no clinical trial availability, let's say, for this patient, just timing wise, it doesn't happen to have an option. Outside of a protocol, you have CTLA-4, maybe you could get IPI off label for this patient. What do you routinely do in the real world if you have an MMR deficient patient progressing on frontline therapy?
If they got frontline therapy, assuming they got a checkpoint inhibitor and lasted for a while with a checkpoint inhibitor, I think the off-trial standard is we're still stuck with chemotherapy. So I certainly have used CTLA-4 inhibitors there off-label and on some level somewhat successfully, but I would be forced at that point to revert to chemo. I will say that the sensitivity of these patients to chemotherapy isn't that great, especially in second line. Even if you're forced to do so, which in the real world we're often forced to do things like that, I would have a backup plan in place because I don't expect that they're going to have that much durable benefit from, let's say, a PAC-RAM combination the way other patients might.
Yeah, I completely agree. We're really flying a little bit data-free in this space. Honestly, I've done like PAC-RAM and continued Nivo a couple times. There was a phase 2 trial, but that was all in PD-1 naive patients. I've also tried CTLA-4 as a way to salvage progression, and mixed results. Definitely had a few successes. So I agree. It's a space where we do need data and is wide open, but not so straightforward to develop as a drug company since these patients do so well in frontline therapy. We just got to wait a while to find them. Let's talk about a new data set which has been presented but not really published yet. Maybe it's additive data, but we've seen obviously fruquintinib in colorectal cancer, and now we have seen this Frutiga study. You want to just remind the audience the trial and the main findings?
Fruquintinib is an oral VEGF TKI, in essence, a more potent version of perhaps regorafenib and a number of other drugs that are similar in nature. And the study design was done in China exclusively, to my knowledge, and randomized patients in second line to either paclitaxel alone or paclitaxel plus fruquintinib, and the endpoints were progression-free survival, overall survival, and the study met its endpoint by improving PFS by almost a couple months and survival by a month and change. So number one, the survival wasn't that statistically significant, and they had to do some post-hoc analyses to even show that it was nominally significant. So I thought that was a little underwhelming. Secondarily, I do think that, it does correspond with our notion of combining VEGF inhibitors with paclitaxel. I certainly don't see this as sufficiently different from the data sets that exist with ramucirumab, and also regarded as an option that wouldn't be anything we would consider in this country, certainly in my opinion at this time. So we're seeing an explosion of clinical trials in gastric cancer from Southeast Asia, and some of them have relevance, some of them don't. So we kind of got to take each one as it comes and think about what it means for us.
Yeah, agree. I mean, kudos to them for going into the second line space, as you said, and agree, perhaps relevant to areas of the world where RAM is still harder to access, which is sad, but quite true. In the last couple minutes, second line therapy is limited, so we covered most of it in 20 minutes, but let's talk about some newer targets. So you've led some of the FGFR2B work and have thought about FGFR amplifications, etc. Just remind us very briefly the data sets that's out there and sort of the trial that we're waiting on to see if we get another tool for the toolbox.
Yeah, so FGFR inhibitor has been out there for a while. And gastric cancer, this is a monoclonal antibody, bemarituzumab, which blocks FGFR2B, that isoform. And, we're able to demonstrate that in a group of patients, which probably represent about 20% of HER2 negative patients that overexpress this target by either immunohistochemistry or amplification, the drug adds benefit to chemotherapy. And I think that was pretty clear in the randomized trial, the FIGHT trial, and hopefully that's replicated right now. We're doing the 2 large randomized phase 3 trials in front line, either with nivolumab or without nivolumab, and looking to add bemarituzumab to the equation for frontline patients. So time will tell. The trials are enrolling, and some of them are nearly enrolled. Next few years, we'll see if these trials meet their endpoint. I think we're cautiously optimistic, but as we all know, in this space, there's a lot of complications and a lot of heterogeneity, and clinical trials are not easy. But hopefully we'll see something in the next couple of years for a new biomarker. Now, that'll represent another frontline option. And I do think in some respects, while frontline is very important because patients are on therapy the longest, patients all progress. And so we do need to do, as I mentioned earlier, I think a better job on second line and beyond trials. I am excited about another antibody-drug conjugate, a TROP2 antibody-drug conjugate, which is another what I would consider novel target in this disease, borrowing from breast cancer and lung cancer. There are a few TROP2 ADCs out there, and new trials are being launched in more refractory settings where patients eventually find themselves. So we can't ignore the realities of this disease. We all want better frontline therapies, of course, but we also have to have, in my opinion, just as equal emphasis on later line therapies. Those are going to drag long-term survival as well.
Yeah, you beat me to it. I was about to ask you what targets in later line you were thinking about on your mind. And I think now we're seeing Claudin ADCs. Maybe we'll add in the later lines. Maybe we'll see FGFR2 ADCs, post monoclonals in the front line. Who knows? A lot of interest in redeveloping and re-exploring some of these surface antigens and features that we see, MET, EGFR, etc. Well, look, we're basically at end of time. So for all those listening, thank you. Today we talked to Dr. Wainberg about standard of care, second line and beyond therapies. We talked a lot about roles for Taxol and RAM in particular molecular subsets such as MSI high and MMR deficient and HER2 positive, and how to think through these patients as they progress through frontline. Thank you for tuning in. Please take a moment to download the Medscape app to listen, subscribe to this podcast, and thank you very much for listening to this Medscape in Discussion Esophageal Cancer podcast.
Thanks for listening to Medscape's In Discussion Esophageal Cancer podcast series with our host, Dr. Samuel J. Klempner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on esophageal cancer.